Radiculopathy is a clinical condition that occurs when a spinal nerve root is affected, often resulting in pain, weakness, or numbness radiating along the nerve's path. The most common causes include disc herniations, spinal stenosis, degenerative changes, infections, and metabolic or demyelinating processes. Accurate diagnosis is crucial for effective treatment, and two primary tools are used: electrophysiology, particularly electromyography, EMG, and magnetic resonance imaging, MRI. This video explores how these methods contribute to diagnosing radiculopathy and compares their strengths and limitations. Let's begin by understanding what each technique offers and why their combination is often recommended. Accurate diagnosis of radiculopathy is essential because it guides treatment decisions and helps prevent unnecessary interventions. Misdiagnosis can lead to ineffective therapies or even surgery that might not address the underlying problem. Both EMG and MRI provide unique insights. MRI reveals anatomical changes, while EMG assesses nerve function. By combining these tools, clinicians can better pinpoint the affected nerve root and understand the severity and progression of the condition. This comprehensive approach ensures that patients receive the most appropriate and effective care for their specific situation. Electromyography, or EMG, is a key tool in diagnosing radiculopathy. It involves measuring the electrical activity of muscles to detect nerve root involvement. EMG can identify the specific level of radiculopathy and provide information about the severity and course of the condition. By examining multiple muscles innervated by different nerves but sharing the same root, EMG helps distinguish radiculopathy from other nerve disorders. This functional insight is something that imaging alone cannot provide, making EMG a strategic part of the diagnostic process. Magnetic resonance imaging, or MRI, has revolutionized the diagnosis of spinal conditions. MRI provides detailed images of the spine, including discs, vertebrae, and nerve roots. It is especially useful for identifying structural abnormalities such as disc herniations, spinal stenosis, and foraminal narrowing. However, MRI shows anatomy rather than function, so it may reveal abnormalities even in people without symptoms. This means that while MRI is highly sensitive, it may not always correlate with a patient's clinical presentation or nerve function. A recent study compared EMG and MRI in diagnosing radiculopathy. Researchers analyzed data from 170 patients who had both EMG and spinal MRI. The goal was to determine how well these methods agreed and which provided the most sensitive results at different spinal levels. Patients included in the study had either cervical or lumbar radiculopathy, and their results were carefully evaluated to assess the diagnostic capabilities of each technique. This approach helps clarify when each tool is most useful and how they can complement each other in clinical practice. Among the 170 patients studied, 40% had cervical radiculopathy and 60% had lumbar radiculopathy. The average age for cervical cases was around 52 years, while lumbar cases averaged about 55 years. Both groups had a slightly higher proportion of male patients. Right-sided symptoms were more common, especially in cervical cases, while bilateral involvement was more frequent in lumbar radiculopathy. Understanding these demographics helps clinicians anticipate which patients are most likely to present with these conditions and tailor their diagnostic approach accordingly. The EMG protocol in this study followed established guidelines. For suspected radiculopathy, needle EMG was performed on multiple muscles innervated by the same root but different nerves. For cervical radiculopathy, muscles like the biceps, deltoid, and triceps were tested. For lumbar cases, muscles such as the rectus femoris, tibialis anterior, and peroneus longus were examined. This comprehensive approach ensures that the diagnosis is accurate and not confused with other nerve or muscle disorders. The inclusion of both limb and paraspinal muscles increases the sensitivity of the test. MRI grading systems are used to assess the severity of foraminal stenosis, which is the narrowing of the spaces where nerves exit the spine. For cervical radiculopathy, the Kim et al. System was used, grading stenosis from 0, none to 2 severe. For lumbar cases, the Lee et al. System graded from 0 to 3, with higher grades indicating more significant narrowing and nerve compression. These grading systems help standardize MRI interpretation and allow for more objective comparisons between imaging and clinical findings. In cervical radiculopathy, the most sensitive EMG root level was C7, followed by C6. MRI most frequently showed abnormalities at C6 and C5. However, the agreement between EMG and MRI was only fair at C5, C7, and C8, and not significant at C6 and T1. This means that while both tests can identify affected levels, they do not always match perfectly. The combination of EMG and MRI increases diagnostic confidence, especially when clinical symptoms are unclear. For lumbar radiculopathy, EMG was most sensitive at the L5 root, with MRI most often showing abnormalities at L5 and L4. The agreement between EMG and MRI was fair at L4 and L5, but less so at other levels. Interestingly, EMG could correctly identify L5 involvement in over 90% of radiologically diagnosed cases. This highlights the value of EMG in pinpointing the exact root involved, especially in complex lumbar cases. Sensitivity refers to a test's ability to correctly identify those with the disease, while specificity measures its ability to correctly identify those without it. In this study, EMG showed moderate sensitivity and high specificity, especially for cervical radiculopathy. MRI, on the other hand, was highly sensitive but less specific, sometimes detecting abnormalities in people without symptoms. Understanding these characteristics helps clinicians interpret test results more accurately and avoid overdiagnosis or missed cases. While MRI is excellent for visualizing anatomical structures, it has limitations. Abnormal findings are common even in people without symptoms, which can lead to confusion. MRI cannot assess nerve function, so it may miss cases where the nerve is affected but not visibly compressed. Additionally, technical factors like slice thickness and image quality can affect the accuracy of MRI interpretations. These limitations highlight the need for complementary diagnostic tools like EMG. EMG also has its limitations. It may not detect radiculopathy in the acute phase or in cases with pure demyelination. The accuracy of EMG depends on the number and selection of muscles tested, and overlapping innervation can make localization challenging. Paraspinal muscles are not always included in routine studies, which can reduce sensitivity. Despite these challenges, EMG remains a valuable tool for assessing nerve function and confirming the diagnosis of radiculopathy. Neither EMG nor MRI should be used in isolation. Clinical correlation, matching test results with patient symptoms and physical findings, is essential for accurate diagnosis. Both tests have strengths and weaknesses, and their results must be interpreted in the context of the patient's overall clinical picture. This approach helps avoid unnecessary treatments and ensures that patients receive care tailored to their specific needs. Study used descriptive statistics and the kappa significance test to assess agreement between EMG and MRI findings. Kappa values indicate the level of concordance, with higher values representing better agreement. In this study, fair agreement was found at certain root levels, but overall concordance was low when clinical data were not included. This statistical approach helps quantify how well the two diagnostic methods align and where discrepancies may arise. Study found some differences between cervical and lumbar radiculopathy. Cervical cases were more likely to be right-sided, while lumbar cases had a higher rate of bilateral involvement. The most commonly affected roots also differed, C7 and C6 in the cervical region, and L5 and L4 in the lumbar region. These patterns reflect the unique anatomy and biomechanics of each spinal segment and influence both diagnosis and treatment strategies. Both EMG and MRI can produce false positive and false negative results. MRI may show abnormalities in asymptomatic individuals, while EMG may miss cases in the early stages or with certain types of nerve damage. Understanding the reasons for these discrepancies, such as overlapping innervation, technical limitations, or patient variability, helps clinicians interpret results more accurately and avoid misdiagnosis. Including paraspinal muscles in EMG studies can increase diagnostic sensitivity, especially for cervical radiculopathy. However, these muscles are not always tested in routine protocols, which may reduce the accuracy of EMG. The study suggests that testing a broader range of muscles, including paraspinals, can help localize the affected root more precisely and improve the overall diagnostic yield. Diagnosing upper lumbar radiculopathies, L2, L3, L4, is particularly challenging due to overlapping innervation. Muscles in this region often receive input from multiple roots, making it difficult to pinpoint the exact level of involvement. The study found that EMG sensitivity was lowest for L2 and L3, highlighting the need for careful interpretation and, when possible, additional diagnostic tools or clinical information. Experts recommend testing at least 6 muscles, including 1 paraspinal, for both cervical and lumbar radiculopathy. This approach maximizes the chances of detecting nerve root involvement and reduces the risk of missing subtle cases. The study supports this recommendation, noting that broader muscle testing improves diagnostic accuracy and helps differentiate radiculopathy from other neuromuscular disorders. Findings of this study have important clinical implications. They reinforce the idea that neither EMG nor MRI alone is sufficient for diagnosing radiculopathy in all cases. Instead, a combined approach, integrating clinical evaluation, EMG, and MRI, provides the most reliable results. This strategy helps ensure that patients receive accurate diagnoses and appropriate treatments, minimizing the risk of unnecessary procedures or missed pathology. Like all research, this study has limitations. It was retrospective, meaning it relied on existing data rather than prospective clinical evaluation. Clinical symptoms and physical findings were not included, which may affect the interpretation of EMG and MRI results. Additionally, technical factors such as MRI slice thickness and the selection of muscles for EMG could influence the findings. Recognizing these limitations is important when applying the results to clinical practice. Based on the study's findings, clinicians are encouraged to use both EMG and MRI when evaluating patients with suspected radiculopathy. EMG is particularly valuable for assessing nerve function and confirming the diagnosis, while MRI provides detailed anatomical information. Combining these tools, along with a thorough clinical assessment, leads to the most accurate and effective patient care. The study highlights the need for further research, especially prospective studies that include clinical symptoms and physical findings. Future work could explore new imaging techniques, improved EMG protocols, and better ways to integrate clinical and laboratory data. These advances will help refine the diagnosis of radiculopathy and improve outcomes for patients. Summarize, both EMG and MRI play crucial roles in diagnosing radiculopathy. EMG is best for assessing nerve function, while MRI excels at visualizing anatomical changes. Their combined use increases diagnostic accuracy, especially when clinical findings are unclear. Understanding the strengths and limitations of each tool helps clinicians make informed decisions and provide the best possible care for their patients. Ultimately, the goal of any diagnostic process is to improve patient outcomes. By using a patient-centered approach that integrates clinical evaluation, EMG, and MRI, healthcare providers can ensure that each patient receives a tailored diagnosis and treatment plan. This holistic strategy not only improves accuracy, but also enhances patient satisfaction and quality of life. Effective diagnosis of radiculopathy often requires collaboration between neurologists, radiologists, and other healthcare professionals. Each brings unique expertise to the table, ensuring that all aspects of the patient's condition are considered. This multidisciplinary approach is especially important in complex cases or when test results are inconclusive. Advances in technology continue to improve the diagnosis and management of radiculopathy. New imaging techniques, more sensitive EMG devices, and better data integration tools are on the horizon. Staying up to date with these innovations helps clinicians provide the highest standard of care and adapt to the evolving landscape of medical diagnostics. Educating patients about their condition and the diagnostic process empowers them to participate actively in their care. Clear communication about the roles of EMG and MRI, as well as the importance of clinical evaluation, helps patients understand their diagnosis and treatment options. This partnership between patients and providers is key to achieving the best outcomes. In conclusion, the diagnosis of radiculopathy is complex and requires a multifaceted approach. EMG and MRI each offer valuable information, but their combined use, along with careful clinical assessment, provides the most accurate results. By understanding the strengths and limitations of each tool, clinicians can make better decisions and improve patient care. Thank you for joining us on this exploration of electrophysiology and MRI in the diagnosis of radiculopathy.